symptoms of certain clinical types of renal infection. Although the pathological and clinical picture already described covers the various types of renal infection, whether acute or chronic, whether occurring in infancy or in pregnancy, whether due to urethral or ureteral retention, nevertheless, certain clinical types of renal infection exhibit certain dominant characteristics which merit notice. We may enumerate renal infection in infancy, renal infection in pregnancy, renal infection due to urethral retention, renal infection following surgical operation, renal infection due to typhoid fever, renal infection due to the gonococcus. Renal infection in infancy. Renal infections are extremely common in infants under 2 years of age. They are said to be 10 times more frequent in girls than in boys. The acute onset may be so mild as to be overlooked, though usually it is very stormy. Thus, we may describe the acute and the chronic type of infection. Acute renal infection in infancy, usually spoken of as the pyelitis of infancy, is usually a stormy attack with chills and high fever, tenderness in the loin, rigidity of the overlying muscles, enlargement of the kidney. These local signs have to be sought for the infant does not localize its pain. The debility of the patient is relatively slight as compared with the fever. It is said that malaria and acute renal infection are the only causes of septic fever with repeated chills in infants. Though the attack is often very acute, it rarely requires surgical treatment. The patients ultimately recover or pass into the chronic type of renal infection. Chronic renal infection in infants is a toxemia of the mild digestive type. There may be no fever. There may from time to time be acute attacks of infection. The kidney is not likely to be tender. The diagnosis depends upon the examination of a specimen of urine obtained by catheter. Unfortunately, the attending physician is very unlikely to think of this means of diagnosis. Townsend has called attention to the fact that chronic perinephritis occurs in children, causing lameness and muscular rigidity as its most striking symptom, and is usually mistaken for spondylitis or hip disease, or even for psoas abscess. The diagnosis can often be made only by operation. Renal infection in pregnancy. We have as yet no adequate data to help us determine what proportion of renal infections occurring during pregnancy are derived from latent infections of childhood. The infection may be bilateral, but the acute infection is almost always in the right kidney. The chronic infection is almost always mistaken for toxic albuminuria, from which it can only be distinguished by the examination of a specimen obtained by catheter from the bladder. Acute renal infection occurs on the right side, is more frequent in primipara than in multipara. It may occur as early as the 3rd month, but is most common from the 7th to the 10th month. Not a few cases come to operation several weeks after the child is born. The prognosis of the attack depends almost entirely upon the treatment. Early and appropriate treatment should save the child from premature delivery, the mother from operation. Renal infection due to retention. Renal infection is, as we have previously said, usually due to some type of retention. This retention is, in many instances, slight and intermittent. It may be not sufficient to cause any retention of urine in the renal pelvis, but only a congestion of the pelvis and kidney resulting from the slight tension within them. Under such circumstances, the dilatation of the kidney pelvis from retention is a very slow process. But in the type of renal infection of which we are now speaking, the dilatation due to gross retention is the predominant feature. The retention may be urethral or ureteral. If urethral, the retention is felt in both kidneys, but a secondary kinking of the dilated ureter may cause an additional retention in one kidney as compared to the other. Thus, in urethral cases, we may see pyelonephrosis of one side and pyelonephritis of the other. The retention may come on gradually or suddenly. The infection may precede the retention and be lighted up by this, or the retention may exist for some time before infection occurs. The most interesting type of retention infection is that due to catheterization for the relief of prostatic retention. Such retention, if chronic, may be considerable, and yet may have accumulated so gradually that, Previous to the interference of catheterization, the balance of forces may have been so even that the kidneys, as tested by phenylsulfonephthalene, may be working quite well. But the passage of the catheter upsets the balance, excites an acute congestion of the kidney, and prepares the way for the infection that is soon to follow. The mechanism of this infection has been illustrated on page 290. The kidneys become acutely infected, the output of solids falls, the temperature rises, pus and bacteria appear in the urine. The patient goes into a condition of urinary sepsis more or less grave in proportion to the renal destruction that had preceded infection and the intelligence of the subsequent treatment. Renal infection following surgical operations. Renal infection is likely to complicate the convalescence from surgical operation under 3 circumstances. 1, the patient has an unsuspected cause of urinary retention, usually prostatism. The acute retention following operation calls attention to this condition for the first time and starts him on the active symptoms of prostatism. 2, without any such pre-existing or predisposing cause of retention, the patient's calls to urinate are neglected in 2 ways. In the first place, while retention is still complete, the house staff neglect to pass the catheter as often as is required to keep the patient comfortable. In the second place, when the patient begins to urinate, he does not fully empty the bladder, but he is then considered safe from any complications, and no further attention is paid to the bladder retention until infection supervenes. 3, the operation itself may have been a cause of retention or infection. The most annoying type of this condition is that type following the wartime operation with stripping of the pelvic ureter for a considerable distance. This results in ureteral atony, dilatation, and infection. It will be noted that each one of these types of retention is due to a neglect on the part of the house staff to appreciate the actual condition present. If a patient has to be catheterized but once or twice after operation, no harm is likely to result. But if continued catheterization is necessary, the case should be looked upon as quite comparable to one of prostatism and treated accordingly. Renal infection in typhoid. In the 3rd to the 5th week of typhoid fever, at least 1 case in 3 shows typhoid bacilli in the urine. The infection is usually symptomless, mild, and readily controlled by hexamethylenamine. Indeed, as a rule, it amounts to little more than a bacteriuria without symptoms. But even these mild cases may continue as latent infections for a number of years, and then develop evidences of more severe or even acute infection. Indeed, typhoid infection acts as a mild type of colon infection with the same possibility of acute or grave complications. These patients are more dangerous to others as typhoid carriers than they are to themselves. Renal infection due to gonorrhea. Pyelonephritis is not an unusual accompaniment of a severe gonorrhea, but the renal infection is very rarely due to the gonococcus. The cases I have seen have all but one been due to the staphylococcus or bacillus coli, usually the former. True gonococcus infection of the kidney is usually mild, but may be tenacious. It seems to be especially amenable to treatment by pelvic lavage.